Thank you, Greg. And thanks to everyone for staying. I'm sure people are feeling quite tired and had their minds expanded in many ways. My job is to try to expand your minds a little further in this talk. I've only got one slide, and I'll explain the last point on the slide at the end of my talk. But thank you particularly to IFA, to TURYAK, and to our many wonderfully hospitable Turkish colleagues who have made me, and I think I speak for all of us, so welcome here in Istanbul. In the last couple of days, I've had some powerful conversations with a number of people, and I was going to mention them, but there are too many. It would sound like the Oscars. But people have reshaped my thinking about how we should be addressing the challenge of care in the 21st century for older people. And I'm grateful, though, and I will just thank two people, Jane Barrett and Greg, for helping to engineer some of these conversations. I've rewritten my talk to try and connect the EasyCare project to the thinking that I now have, and to throw it back to you for discussion and debate. But I will need to explain the EasyCare project in brief. And this is a bit of it has a personal history to it. The person who inspired me to become a doctor working with older people was a professor called Jimmy Williamson, Edinburgh professor of geriatrics, one of the pioneers of my specialty. And he wrote one of the classic papers on healthcare for older people, published in The Lancet in 1964, and it was called Old People at Home, Their Unreported Needs. And it described how 2/3 of the most significant threats to older people's health were not known to their primary care physician. And I would contend that 50 years on, the same is true today in most parts of the world. And as a response to that challenge, in 1989, on a fellowship I undertook with Robert Kane in the United States, we developed an adaptation of the science of geriatric assessment technology to attempt to use it in a primary care setting to help identify those concerns and priorities that older people had about their health and make them known to the system and enable the system to respond in an appropriate way. And that work was initially followed on in Europe, mainly, with a number of projects in a number of European countries to take forward the concept into a practical approach with an assessment tool, with training materials, with guidance. But another key benchmark in the history of this project was the IAGG conference in 2009. John, you'd recently taken up your post as director of Aging and the Life Course program at WHO, and you challenged me just before the conference to globalize this approach and see whether it would work in poor, middle-income, and rich countries, in different cultures, Islamic, Buddhist, Judeo-Christian, in countries which were technology-rich, and in countries which were technology-poor. And my colleagues and I, in our network, took up that challenge. And we now have experience of use of the system in 41 countries that fit all of the above classification. And we know now that we have a stable assessment instrument and a certainty of approach to how we should use it in all these settings. The assessment instrument, which is called EasyCare Standard, covers 7 domains: Seeing, hearing, and communicating is one. Getting around is another. Looking after yourself is a third. Your housing and your finances is a fourth. And I was asked to make the point about the vital need to integrate housing with health and care. Safety and relationships, including relationships within your family and with your caregivers, is another. Your mental health and well-being, we've found, has been one of the most important domains. And finally, we have a domain around staying healthy. We've found that this approach and assessment tool has become highly valued and is acceptable to older people and to frontline assessors, often care assistants or volunteers, sometimes health and care professionals. We've found that it is reliable, and we've found that it can produce 2 or 3 summary scores, one of which I'm most confident in is called the independence score, which seems to correlate with an individual's need for support. We found that when we look at the data that comes back at a population level, interesting patterns where the older people at the end of the assessment is asked, is there 1, 2, or 3 things related to your concerns that you'd like help with right now? And normally they only say one thing. In Tanzania, it was about access to toilet facilities. In Warwickshire, it was about the fact that they were in severe chronic pain. Elsewhere, in many settings, it has been about their loneliness. So we get data which tells us something about the needs of our older populations that we are serving. So this isn't just an instrument, it's an approach. I think a revolutionary and disruptive approach to basing the response to the need of an individual and the development of the health and care system to what older people themselves say they are worried about and what they want help with. Now, the system always needs to be localized. We need, in every locality when it's used, to choose which older people we want to target. We need to think how we will identify them. We need to think how and who will undertake the assessment with them. We need to draw up an understanding of how we can respond to identified priorities for support. And we need to decide how we want to manage and use the information that we gather from the assessment. But we know we can do this. And many people say, what's the point in finding out what older people want if you can't do anything to help them? I hear that in very rich countries. I hear that from development workers in poor countries. But I can tell you that our experience is nearly always something can be done. And always, older people are appreciative that we have listened and we are trying to help. We also know from our randomized controlled trials that we've done in some countries that use of the system in a structured way reduces the number of times an older person needs to go into hospital for expensive care, delays the time that older people may need to go into permanent forms of institutional care, raises the level of independence and capability of the older person, and improves their well-being. We also know that combined with training, our system can help identify problems such as dementia and the onset of frailty at an earlier stage than the system would normally identify people with these high levels of need. So we know a lot about this approach, but we want to move from understanding how this approach works to implementing this approach in a scalable and a sustainable way around the world. we know we need to do more studies on the impact of the system. And I'll be delighted now to work with the World Bank to look at the micro and the macroeconomics of the impact of this approach. And I'm delighted that I'll be working with some of the most wonderful researchers in the world, like Professor Dupeng in Beijing and others, on using this assessment within well-conducted longitudinal studies to see what it tells us about predicting and responding to the needs of older people. And I'm very excited at the opportunity to conduct one of these gold standard studies in Turkey, I hope, from conversations I've had with a number of colleagues here. So, how does this approach fit and support a revolution in care? I will mention 3 people now whom I've had powerful conversations with and listened carefully to what they were saying. David Ryan from Intel described how we need a new social contract for the 60-plus population to move away from welfare and care and to move to empowerment and capability. Linda Fried described how a child born today in a good environment with good health and care can expect to have 30 years of meaningful life above the age of 60. And Amit Sibanchi described how if we could use the huge human capital of older people remaining productive in the years beyond 60, we could add 15 percentage points to the country's gross domestic product. These facts change, indeed I would say revolutionize, our future and the future of aging. And in a modest way, but in a global way, EasyCare can make a contribution to that agenda. First, EasyCare by its nature shifts the focus on the older person's care from the provision of care to enhancing capability and independence. Second, EasyCare moves away from a response that classifies and gatekeeps and directs care to older people to one which empowers older people to find the solutions which work for them. Third, the EasyCare approach changes our approach from a professional or a system definition of need to a user-defined definition of need. Fourth, EasyCare moves us, potentially, or helps to contribute to move away from a segmented world of poor, middle income and rich, of Buddhist, Judeo-Christian, Muslim worlds, of technology-rich, technology-poor, to a connected world where we face the same universal challenge and we can respond with a common global approach. Fifth, the EasyCare approach allows us to rethink aging from an economic burden to an economic asset. And sixth, EasyCare helps us rethink family caregiving from a burden to the contribution that older people can make at the apex of their families. Now, I've had the opportunity here to make lots of plans with a number of fantastic people for our next 5 years' work. And I truly believe that this meeting is as important as the 3 milestones I described in the history of this 25-year project. And I thank you sincerely to all of those of you who have helped with the program, from colleagues in the EasyCare network who are here, who've been doing research in their countries, to many of our advisors, and to some of my new friends. And I look forward to working with you in the next few years on a journey where I think we can revolutionize the care of older people throughout the world so that we can give the children of tomorrow and the older people of today more years of a meaningful life. Thank you very much for your attention.